conversation about integrated care really intensified some 20 odd years ago when the data that showed that people with serious mental illness die 25 years earlier than the general population came out. And that became kind of a call to action. About 20% of the Medicaid population was costing about 75% of the costs in terms of inpatient and emergency utilization in particular. And when we also found out that about 60% of this excess mortality could be explained by treatable and preventable medical conditions, that was when I think people really started to mobilize to look for different models of care, look for ways to not only save costs but save lives. And so I've been privileged to be part of this really exciting work at ICL and across the system to address these issues. We've asked ourselves often why people with serious mental illness would have such an increased mortality. And I think what we understand is there are a few different factors involved. One is, for instance, that people with schizophrenia have a lot of negative symptoms. They don't have a lot of motivation to get up and exercise and do things to take care of themselves. They also live in places that are what we call food deserts sometimes. They often can't buy healthy foods in the neighborhoods where people live. Mental illness can be associated with poverty and loss of income, sometimes even with homelessness. So that has really impacted their health as well. Substance abuse can be an issue among some folks who have mental illnesses. When you have disabling symptoms, anxiety, depression, hearing voices, you look to what you can to try to make those things better. And sometimes smoking or drug or alcohol use provide temporary relief. Well, we know that people with serious mental illness often also have a lot of trauma, and that because of their illness, this risk of trauma increases. And that has likely led to very adverse health outcomes for them, both in terms of increased mortality, heart disease, liver disease, and in terms of mental health outcomes. And so what I'm excited about is the potential for the behavioral health workforce to address a lot of these risk factors. Somebody might see their primary care provider at most every 3 months, usually probably 6 months or a year is how often they go to see them. But in behavioral health, often we have folks who are living in residences where they see case managers every day, or attending clinics or day programs where they see people at least once a week. So a behavioral health worker then has this opportunity to really work on a close basis with someone on addressing their healthy eating, physical activity, smoking cessation, all of the things that could improve their health, medication adherence as well. So what we've really developed at ICL is a way of enhancing the capacity of our workforce to support self-management among people who have mental illnesses. And that involves really starting with person-centered care, thinking about the goals of somebody who has mental illness. While the doctor might feel that the goal is to take medications and get better and get rid of the voices, the person's main concern might be, how am I going to keep this part-time job that I finally got? For us, that needs to be the goal, not the taking medication or whatever we think is important. If this person wants to keep this job, how is managing their diabetes relevant to that? And it may very well be that if you're being hospitalized every couple of weeks because your blood sugar is out of control, then maybe taking medication as prescribed or eating healthy and monitoring your glucose is going to help you keep that job. And so what we try to equip our workforce to do is to know motivational interviewing and to know the stages of change and how you can respond at each stage of change in ways that help somebody to make behavior changes towards better health. And these have to be done in small steps. I think sometimes people come to me and say, okay, my goal is to lose 10 pounds by Christmas. You know, I had a patient who would drink a Hawaiian punch with breakfast, one with lunch, and one with dinner. And our goal was to just decrease the breakfast one, so that you can drink it 2 times a day rather than 3. If he's able to make that change, it gives him this sense of success that might be able to decrease the lunch Hawaiian punch and so forth. And so, we work step by step with folks. For our behavioral health workforce, where we get people who have complex medical conditions come in, I think one thing that the system should invest more in is nurse care management. If we have a nurse supporting a number of behavioral health care workers in understanding and triaging health risks and in being a liaison with outside medical providers, we have the capacity then to manage pretty complex risk across the system. And at ICL, for instance, we've developed a clinical high-risk management system where every month each program submits a list of the people that they've been most concerned about for either psychiatric or medical risks. And nurses look at these lists and what is the reason for concern and what are the interventions that we're providing, and see if there are opportunities to enhance the care that we're providing. And on our outcomes department processes the data that comes in to see if across the system there are any trends that we could be responding to as well. So when ICL looks at outcomes, we've been able to decrease emergency and inpatient utilization for the people that we serve. We also look at health indicators like blood pressure, body mass index, A1C levels to look at diabetes control, and lipid profile. And we're excited to see some positive results in that as well, and particularly positive results in smoking cessation. Our measurement of health outcomes separated by different racial and ethnic groups has helped us to look at health disparities that have been very apparent across the United States, and to look to see if we are making difference for groups that have been traditionally very underserved and for neighborhoods that have been underserved, which I think is the population that ICL really cares about.